Okay, thanks guys for coming. We are going to start now. So Julia, I'm going to actually unshare my computer. Right, so let me do this, stop share, and it's going to you.
Okay, let me do this. Okay, can everybody just see my PowerPoint?
Yes.
Okay.
Well, we
And
can see the slide master though.
okay, that's okay. I just wanted to make sure you couldn't see my messy desktop. Let me now slideshow. Okay. All right. Should I get started, Dr. D? Okay, great. So I'm giving surgical conference today. I'm Julia. I'm one of the second-year fellows. So this is a case that I did with Dr. Pinhas a couple months ago. And I figured it'd be a good opportunity to just talk a little bit about PVR, how to approach PVR, some of the questions I've had about PVR, like introp, Nilesh and I were talking about it the other day too. We're like, just like, how do you know when to stop? Do you just like keep putting perfluoron down and wait for it to flatten and just like pray? So we'll, gotta go back to my roots. So anyway, so we'll start with the case. This is a 71-year-old female. She came in from an outside retina specialist for choroidals. That's what she came with. Her sheet said surgical history. She had a history of cataract surgery back in March of 2022, complicated by retained lens fragments. They then did a surgery to remove them. Her IOL subsequently dislocated. She had a PPV with an explant. They put an AC-IOL in June. And then her course was allegedly complicated by CME, for which she was getting subtenon's Kenalog. So when she came to us, she was hand motion. Her pressure was 6. She was very exquisitely tender to palpation. When you even came close to the eye, she was like, ugh. She had ciliary flush. She had this ACIOL, otherwise some trace cell in the AC. Again, like a little bit of chorectopia of the iris, just based on where the ACIOL was sitting. Otherwise, left eye was fine, 20/30, totally normal exam. This was her DFE. So significant, notable choroidal effusions, as well as what appears to be looking like probably a rhegmatogenous retinal detachment component overlying it. I have a B scan from that day too. I thought the first thing that was interesting is just kind of how to approach this patient when they first came in. I don't know if I should ask questions, but this is a conversation I had with a couple attendings. Like, do you take them to surgery right away? Do you start drops? Do you do a workup for the choroidals? Is this more of a uveitic type picture? And how would you approach this patient? I can tell you what we did though.
Yeah, I mean, what do you guys go ahead?
What was the pressure?
6.
6. Yeah.
Yeah, I guess Carl, you're a resident uveitis, surgical uveitis guy too. So, do you think that this is uveitic?
Yeah.
So for the most part, when these folks come to you, that it's not uveitic. So now if this pressure is 20 and he has some history of something else, or the fellow eye has any suggestions, then sure, there's no harm in doing a workup, but sometimes you go down a rabbit hole for no reason. The other thing is that when you get these detachments that might be you really shouldn't wait very long to fix them. So I do find that sometimes they end up in this sort of delay to get to surgery,
We were just talking about that, yeah.
Yeah, it's really because as you're talking about PVR, it gets to be a complete and total mess. So as soon as you can quiet them down within a week, usually a week or two, you can take them, even if it's a true uveitic detachment. So
and that also looks almost like, at least the fundus photo looked almost not kissing, but at least the retina was positional.
Agreed.
So it's very, very difficult to manipulate retina if it's sitting close together like that for a very long time. So right there, that's very concerning. I guess the real question is, when we quiet them down, I know, Carl, you and I have had cases, not exactly like this, but where, how much, what's the oral steroid component that you would give, if at all, and for how long? I don't know if I saw deep in this, Dr. Parikh on this call right now, but yeah, I mean, that is the one thing that I would say, that you just don't want somebody to have an inflammatory reason for this. So you might almost preemptively treat and then think about going in as
Yeah.
quickly as possible.
That's
It- it ac-
exactly.
It actually turns out to be really rare that the uveitic patients get these choroidals. They get it. We've all seen it, but it actually turns out to be quite rare. Serous detachment, yeah. But usually when they get that far, they're essentially the eye is shutting down from end-stage uveitis. So usually you see something else, right? Like crenated KP or the corneas
Right.
toast or so, something.
Yeah, she
It's
was
a-
she the only thing was she was super like tender, and she did have kind of like the ciliary flush, but
Yeah.
there was no like
Pressure
forward
very low?
obvious AC. Say that again?
The pressure very low?
Yeah, six.
Yeah.
It's not that low.
Yeah, no.
It's okay. So I mean, the chronic uveitis when the ciliary body shuts down, right? You could get that, but it's usually not. So and then I do the full dose steroids, 60 max, but 1 mg per kg. And the steroid dosing, the way that it works within about 48 hours for the prednisone. So I mean, you can take them within a week usually if they're quieted.
Yeah, we ended up she's a very tiny kind of elderly lady, so I think we ended up doing 40, but we did do Perioperative for a week. Her pressure came up to like the mid-teens, and she was definitely just much more comfortable, but her exam really didn't change much. So at that point we took her to the OR 1 week after she presented. We did send like a limited infectious workup too, syphilis, TB. Okay, so this is, oh no, why? Okay, good. So, getting in the OR, of course, just even getting access at first is difficult. So we can't see anything. We're checking our light pipe to see if we can even just get an infusion, and we're able to get an infusion. This infusion in this one is definitely doing some drainage for us, which was very helpful. And then of course we have to replace that port more anterior. As you can see, she's got the ACIOL.
Julia,
So-
did you guys I'm sorry, I've just
No.
Did you guys give a thought to sort of pre-placing that first trocar instead of, I mean, it looked like what you did was a standard 3-port pars plana.
Yeah. So you're saying like put it in, establish infusion before wait, say that again. Sorry, Dr. D.
No, I just meant that, because the choroidals existed prior to the case. So did you localize your trocars
Oh,
that
yeah.
you would drain
Yes.
them in this fashion?
Yes. We were thinking about exactly where our choroidals are. Absolutely. Yeah. And we even talked about it before the case. So this is us just kind of like looking and seeing what's going on, especially once the choroidals have drained a little bit. It's much easier to actually see what's going on in the retina. So depressing, we find a very small break at this point where like our view isn't great. So we put in iris hooks. We put down some perfluoron just to stabilize the posterior pole and kind of see what's going on here. And at this point, we realize that it's really right external to posterior pole. We do more of a vitrectomy. That's what that was. There's like this napkin ring of subretinal bands. So we do this access retinotomy to get down there. You can see that there's schlaring coming out. This is just with the max grip forceps, just kind of grabbing at that band. I feel like almost at this point, it would have been nice to have like a chandelier. I used one with Dr. Land on Wednesday, maybe just to have like two max grips to be able to really manipulate the tissue rather than having that light pipe. So I think in retrospect this is the part that Dr. Pinhas and I, after the case, were like, so at this point, we are able to remove a fair amount of the subretinal bands, but they're still out nasally, this area. So we decide to make a larger break. We diathermize, we make almost like a retinectomy or large retinal break superiorly, which we think in retrospect, probably we didn't need to do because we were concerned about potentially leaving these bands out temporally. But in the end, we really weren't able to access them. We took down some of the perfluoron just to see if there's anything more pre-retinal going on. And we were able
Were the bands holding the retina up?
So they were, Dr. Rosen, when we first did it, but then just that relief of essentially the napkin ring like this, just breaking this part of the napkin ring and removing some of it was enough to flatten.
Yeah, I found that a lot of times you can leave that
That's what we didn't really realize in prop, yeah.
and that you really, it's only when it's really holding things up, and sometimes you just cut it and it releases.
I think that's exactly what happened, because I think actually really all we needed to do was this access retinotomy. I think with the chandelier would have been helpful. 2 max grips kind of just pull and break the rubber band at one point, and then it relaxes. Whereas we kind of yanked half of it out, left half. We're worried about it, ended up making a bigger break than I think we needed to try and get to it. Didn't even get to it.
Did you do a buckle?
We didn't do a buckle. No.
You know,
But
I'm sorry, I didn't want to interrupt anyone, but
no.
I always, say in these cases, you have to think about what you're like the thing you're doing and whether that's solving the problem. And of course, in this case, when you make a cut like that, you're probably exposing the RP. I don't know how big that tear is, but it looks like it's probably exposed now quite a bit, the RPE to the vitreous cavity.
Nick or
And
PVR.
right. And so you're almost asking for it. And I think that, already seeing that a subretinal band formed, right, is sort of emblematic of the fact that PVR is probably coming.
Yeah.
Right? So it's sort of this eye is kind of ready to do that. I think Matt Weeder actually and we had choroidals and a lady who we did a similar thing. We had to do a 360 retinectomy, but we left a little isthmus, and then she just redetached again because we had we actually, there was PVR, and I don't think we grabbed, or made too much of a break or anything, but it's just these eyes are prone to that,
Totally.
So.
And then one more thing, just in general, you guys had all this scleral coming out. That's probably PVR-ogenic too. So it may be worth just vacuuming that all out before you start working under the retina, because you're just exposing the entire surface of the retina to all this junk. So I tend to do that before I work on these cases. And I agree, you don't need to cut the whole thing as long as the traction's relieved. You could probably leave it be. So that's correct what you're saying.
Yeah, we had a case. It's the patient with the cards, Dr. Deobhakta. He also had some subretinal bands. The RD we did, and you were like, let's just leave them. And he's fine. He flattened and he's attached now, like, I don't know, 5-6 months later.
Yeah, I mean, I like to put a buckle on because
yeah, of course.
Eyes are these eyes the retina tends to be sort of shrunk, even if you get, most of the PVR off the surface, and sometimes you wind up leaving some bands. So it gives you a little bit of help. Sometimes you still wind up having to do a big retinectomy, depending on how severe it is. But I found that in many of these cases, just the added support in the periphery, I don't have to do a big retinectomy.
Does your calculus on that change if this person has a bunch of choroidals? I'm just asking. I mean, or is it like, does the buckle?
Well, it depends on the choroidals and how quickly they flatten. I agree. There's definitely, with choroidals, I think about it a little bit differently. But
is there a time frame, Dr. Rosen? Is a couple of those patients, you put the buckle first and then you do the vit. So I put the buckle and then it ended up not supporting anything. It's just like.
Well, no, that's true.
Yeah.
I mean,
it's just a phantom buckle.
It's not.
Yeah.
It may not help you, but
because I cut everything out.
Yeah. Putting the buckle on after you've done the vitrectomy is often very difficult. That's how we used to do it years ago, and it was like a nightmare.
Nilesh and I did that once for a PVR case with Dr. Lane. It's hard with the trocars in, and you're trying to
it's a mess. It's definitely.
We were both like, we're not doing this again.
How much easier to put it on the beginning and just say, okay, it's an abandoned buckle.
Yeah, no, definitely. I mean, I think that for me, at least the way we think, I feel like chronic detachments, PVR, I'm like, okay, this patient gets a buckle. But I guess with the choroidals, that makes sense that it's going to completely change the anatomy with placement. So you have to think about that ahead of time. That didn't even click in my brain.
And it's often soft, so the buckle's painful.
So, oh gosh, I can only imagine. Yeah.
Well, but you said the pressure came back up into the teens.
Did. It wasn't bad. Yeah, it wasn't bad. It was in the teens.
But sometimes they don't. If I have just choroidals, I won't necessarily do a buckle.
I would tend to agree, Julia, with your conclusions about buckle during vitrectomy. I never put on after second vitrectomy anymore, and I usually plan ahead to do it. I've never regretted putting a buckle on. In these cases, it supports it supports any retina that you don't do retinectomy on, and it even supports your, sort of the corners of the retinectomy and the superior retina. So I don't see a downside.
Yeah. Thanks, Dr. Lema. I mean, I totally agree. So here we're kind of working on the more pre-retinal, and there were definitely some pre-retinal membranes there. And then at this point, we put down perfluorine. A question I had is there any sort of mantra you need to follow in terms of attacking pre-retinal before subretinal or subretinal before pre-retinal when it comes to this PVR cases? I mean, I know in terms of like, posterior, anterior, but, or does it just kind of whatever comes to you?
Well, it matters if you're putting down PFO first, right?
Yeah.
So when you first went in, you put down PFO. Presumably it's because the PFO could access, the posterior pole. If
Yeah.
it can't do that, then it starts
You
to
have
form.
to do, yeah.
But you
Yeah.
have to first at least get a space,
Yeah.
which you guys did, and that just sort of makes sense. The second thing I think is right is for you guys, once you determine that there was subretinal bands, you have to get rid of that or remove that traction. So you can expose the pre-retinal bands, and then you go posterior to anterior as opposed to AP in the setting of a diabetic TRD.
Yeah.
Again, to keep snaking up that PFO.
But you need something to pull. You need something to pull on. Yeah,
But
I didn't know
it's always case specific. But I mean,
Okay. So at this point, we put down perfluorine, and I think in retrospect, obviously we were saying to ourselves, like, okay, we did not need to make that big wound. We really didn't end up doing much with it. And she actually flattens quite nicely after just removing that, just kind of almost snapping the rubber band and removing those pre-retinal membranes. So this is her under perfluorine. The rest of the case is relatively straightforward. She flattens really nicely. We end up going to air. We drain from the large break that we made. That was, thankfully superior. You can actually see temporally, those are those subretinal bands that we were worried about. And because they don't have something anchoring to them, I think they flatten nicely. So now it's just kind of almost like a bump in the road. So we're going to air.
I guess, as you do this, Dr. Lema is our sort of resident expert on doing the methotrexate sort of prevention analysis here. And I wonder, like, Dr. Lema, do you ever consider sort of injecting here, like at this point, the way we do Avastin, like starting the process, because this patient had, I don't know if you were here at the beginning, this patient had choroidals, they sort of drained them, had, appositional retina, detachment, total detachment, basically with the napkin ring that was subretinal, and they removed all of that. So then they made a retinectomy. So it seems as if this is a patient that would be more likely to get PVR than less. Do you ever think about adjuvant sort of, or
are you saying like before this patient has PVR, right?
Yeah, well, exactly. Right.
So, but in terms of at the time of surgery, that's the protocol. In fact, the Cincinnati protocol started with using it in infusate. They would put the whole bottle of methotrexate in infusate during the surgery, and that was their paper, just using it during surgery. And they added on a protocol we've been using quite a bit with you inject it at after surgery 1 week, 3 weeks, 6 weeks, 10 weeks. I kind of think that's not far enough. I did have one patient who I did that, stopped at 10 weeks. He went home to Ecuador and came back with raging PVR. So I tend to like going to 4 months like the clinical trial does. But I think a lot of the dosing is a little bit unknown. Like 400 micrograms is good. I would answer the question with the OR. I just inject 400 micrograms at the end of the case.
Okay.
So I do the injection, but other than that, we probably don't need it as much as every week for 2 months and every other week. But that's what the clinical trial is. The Cincinnati protocol is a little bit more humane and so has less effect on the cornea, but also there might be a little more breakthrough PVR because it's less intensive. I think that's going to be figured out over the next several years. People start using it.
Sure.
Cool. Thank you. Yeah, and we didn't end up using it for this case, but was thinking about it. And then we put oil in, and I think just like for the residents and everybody, like oil and any sort of eye that is not bicameral is always like something that you will carry with you forever, because once that comes forward, you know, things can happen. So this is the patient post-op day 1, I believe. I don't. Oh, post-op month 2. Just kidding. Sorry, you guys, everyone's beautiful faces was covering the top. But post-op month 2, you know, she remained attached. She had this loss of, you know, outer retina here in her center. So she went from hand motion to finger count. We were watching her, kind of the plan to keep this oil in essentially almost forever. And she came back for for follow-up post-op month 6. Her vision was still finger count. And then of course the oil came forward. She had like 40 to 50% of her AC was filled with oil, and her retina was attached. It was 6 months out. So we decided actually to take her for oil removal. She just went for PPV oil removal, which we did on Monday, actually at 6 months. This is her post-op day 1. So that superior retinectomy site, I mean, it's always been well lasered. At least right now it's, you know, flat without any membranes, but you know, and we ended up doing 360 laser, which you can see here. I didn't want everyone to just sit and watch us laser for hours, but you can still see this subretinal band over here, which at least for the past 6 months under oil has been hanging out. But I mean, we've taken the oil out, so I guess we'll see. Her vision, she's 2400 now from hand motion, and her cornea, you know, survived the oil. So
She's aphakic, right?
ACIOL.
ACIOL.
Yeah.
So there was an ACIOL, but I guess the question that I'll ask is, if she was aphakic, would you guys have considered doing retention sutures?
You know, I think so, because Dr. Pinhas likes doing retention sutures. So yeah.
But what does Dr. Lee
She's a
actually
pupil.
have on Lee?
How's her pupil?
Her pupil isn't terrible.
I wouldn't do retention sutures if she has a good pupil.
Yeah, you only need those in place of one, right? That was the whole point.
Right. That was the point, because it'll stay back. Did you do an inferior iridectomy?
Yes, we did.
Well, I mean, in this case, it didn't, right?
The oil didn't stay back. No,
So I always worry if the oil doesn't stay back in a case like this, that the retina's coming up somewhere.
Ah.
See anything when you went in?
No, she was flat, but that's like a posterior pressure pushing it forward.
Right, so something pushing it forward. Especially
if have you noticed a correlation for that? That's really interesting. I've never thought of it.
Now I'm like, should I call her back?
No, I mean the question is, if the oil, if you didn't overfill to begin with,
yeah,
and it looks pretty good, and it seems stable, then you know, and then suddenly the oil starts coming forward. I always worry that the retina is coming up and it's pushing the oil forward. And I've seen that. I haven't studied it comprehensively, but that's always been my experience, that when suddenly the oil is, I mean, I'm talking about a fair amount of oil, not like a little bubble that pops forward.
Yeah.
But you know, if I see fair amount, I worry. That's, you know. The other thing is sometimes, you know, if you haven't done a buckle, you might think about it when you're gonna take the oil out.
The oil out.
I mean, it may be belt and suspenders, but you know, just to, you know, if you're concerned that the patient has a risk for redetaching. We'll see.
I know. Is there like a time
Early in the year?
Is there a time frame that I really kind of like, you know,
The first couple of months, I think once the oil comes out, that's when you know, that's when I usually have seen it fail. After that, it's pretty well nailed down. But you know, that's the only time I've seen it suddenly change. But
So I guess the question in this case is, why do you think she had choroidals? Just because it was a long time that she had a retinal detachment, or what was
that was our thought, right? So the thought process when she first came in was like kind of like what came first, the chicken or the egg, trying to figure out and in the end of the day, we thought she was probably chronically detached, which was concerning given that she was going to this other office and getting subtenon's Kenalog chronically for quote unquote CME. So I don't know how that kind of plays into it. You would almost think this subtenon's Kenalog would be helping to the choroidals, but I think our thought process ultimately was that she was probably chronically detached, and that ultimately led to hypotony choroidals.
I think that's right, because choroidals, for some reason, I was always taught by a number of people that was when you would see subretinal PVR develop more commonly.
And that's
I mean, yeah.
She's got
I don't know which came first, but I would suspect that she had low-lying detachment, and her pressure dropped, and then she gradually started to develop some PVR. But I don't know. It's hard to.
Yeah.
And Dr. Rosen, if you buckled this patient, what would you choose? Would you just do a total encircling band? Would you make it broad, or would it just be sort of a standard band?
Yeah, I would probably just do a standard band. I mean, there was a broader one that we were using for a while. It was a little bit wider, but it was still a thin band. It wasn't one of those big 286s like we used to do in the old days.
Yeah.
I haven't really used any of those for a long time. The big tires.
Yeah. Well,
Did you do any of those when you were in fellowship?
who, me?
Yeah.
Yeah, like yes, with Barilli. Actually, Horowitz, oddly enough, we were talking about this. Dr. Horowitz, who's a wonderful surgeon, he always made me do the vitrectomy first and then put the buckle on. So I always had an attending that would make me do that. So
It's hard. It's hard. I mean, Muldoon did that too.
Yeah.
That's how, because he'd say, well, we don't know if we really need the buckle, so we'll wait until afterward. And then he'd say, no, I think we need the buckle. And it's like, shit,
Well, I can now say Dr. Landa did that too, because that was the context that I had it.
That's why I would rather have a buckle that I'm not going to use there than have to go through that, because it's really, really difficult.
Yeah.
Yeah, if you think you need the buckle, you need the buckle. I've just come to learn that. I've never regretted having it. Yeah, I mean, maybe there's been a rare case where I've done a 360 retinectomy and realized it wasn't on the buckle.
That's what I was gonna say, is I've definitely seen a few where like put all this effort to put the buckle on, end up doing a 360 retinectomy, and it's like just posterior to the buckle.
But I think it's I don't know.
You can't predict that. It's certainly not hurting anything by having it.
Well, if you do a 360 retinectomy, I mean, Dr. Chang, every time we do that, he would be like, oh, don't worry, it's supporting the anterior base and anterior PVR and all this stuff it's not going to be as bad. So you just talk into saying that it's,
Exactly.
There's no sunk cost in retinal surgery.
I think, now it seems like it's a big job putting the buckle on for, still at the stage. But I think after you do it for a while, it becomes, it's like this is the fastest part of the case in some ways.
I certainly love when I see, I love putting on a buckle. I think I said this to Dr. D. I was like, I feel like in the beginning of my career, I'm going to want to do a lot of buckle bits because it just feels so much better when it's there.
Yeah. And then the ASC yells at you.
Right? That's what you said. This was the conversation you had, and then you're like, and then you do all vitrectomy.
It's just BB everywhere.
Yeah, no, the ASC does not like buccal vitrectomies, I'm sure.
I guess the question is, because this was sort of a PVR specific case, and maybe again our uveitis people like Carl or anybody else who has an idea, Gareth, we're going to put, let's say we put in methotrexate. Do we give them iodex? Do we go subtenons here? Because this is what they started with at the end of the first case. Do you keep them on oral steroids? Is there a decadron choice? What do we do from that perspective?
I used to do, a long time ago, I used to do sort of higher dose steroids. I would start with 80 milligrams and just taper down 10 milligrams a week. And I thought it quieted things down. The only problem is some patients became symptomatic. So I changed it to a 1 week taper and then kept them on 5 milligrams for 2 months. So I sort of hit them hard. I'll give them a gram of IV solumedrol in the OR and then do a 1 week taper and then just do 5 milligrams for 2 months after that. And that's maybe seemed to work. I never really got to study it, you know. I never really got a chance to do a trial or anything.
Does anybody like to give like 40 of Kenalog at the end of the case?
Dr. Lema.
I mean, I give the rest of the Kenalog because we use Kenalog to stain, and I use the second half of the
like a whole
vial, so it's 20 milligrams.
I'll generally put 40 in if I think the eye's inflamed or it's a re-op or something like that. So I'll give it like I had a case like that on Tuesday, and I gave her subtenons up above, and she looked great the next day.
So you're putting it all subtenons, right?
Yeah, well, the buckle had been done previously. I tried to do just a straight buckle in her, and I think I underestimated the cataract, and how well I was able to see. So we definitely saw when Julia helped me that she had like there was a break. There were 2 breaks, and one was right in front of the other. I mean, they seemed like they were lasered. There was laser around the whole thing, but there was like some chronic. There was some PVR, and there was some chronic changes, and so it just didn't lie flat. And so I figured she probably had some low, some early PVR. So, I gave her the steroids at the end.
Yeah, one of the reasons why I bring this up is because in this case, the eye is effectively unicameral or has an ACIOL. And so, just thinking it through, if you gave the rest at the end of the case, you could get a pseudohypopia if it's Kenalog.
Well, that's why the subtenons is nice, because you give them a big blast of steroids, and then you put them on some PO as well.
Yeah. Just so that others who may not know retinal surgery as well as we do, but IO Dex, intraocular Dex, is not crystalline, so it comes off as liquid. So you don't have that pseudohypopia and fear. But if you inject a lot of Kenalog at the end of the case, you might think the person has endophthalmitis the next day and is quiet because you gave them steroids, and
it looks perfect. It looks like a perfect snowbank.
Yeah.
Well, I've done that where it looks like perfectly white. So,
yeah.
But the problem is,
yeah, right.
If you do the Dex is nice, but it only lasts for a couple of days, so it doesn't really,
Right.
You can give a lot. I mean, because you got more space there, so you could put 0.3 or something like that.
Yeah, I'm not a big fan of injecting triamcinolone into oil because I've seen it get smashed up against the retina between the oil bubble and just collects there as this like plaque between the oil and the retina. Yeah, and it caused atrophy. So I'm not a big fan of it for oil.
Definitely a problem. I mean, so years ago, the group from Hopkins came out with this thing. Oh, they put Kenalog, they washed it, and then they put it under this oil. And I came back and I explained this to Dr. Muldoon. He goes, okay, let's try it. That the oil of the Kenalog never moved. I mean, there was this white plaque there for like ever. And
did it cause atrophy underneath it? I thought this time
it somehow got encased. It never disappeared. So I stopped doing that.
I think Dr. Barash and I looked into this once because we had a MAC hole where we put down Kenalog, or we put down, to lift the highlight, of course, and the Kenalog ended up going into the hole, and it ended up like a little bit of its subretinal. And so the next day we were like, and I think I don't know if you remember, Dr. Barash, we like looked at a couple case studies, and it was kind of like the jury was out about whether or not, but some people did report like significant atrophy. Now that's obviously subretinal as opposed to sitting on the retina, but
I think most studies say you can leave it under there, but I don't know about subfoveal. But if you get subretinal somewhere, that you don't have to go after it.
I think subfoveal goes well.
One of the issues I think is that if there's oil in the eye, because Dex or because some of these things it changes the way that it sort of like diffuses in the vitreous, so it'll actually go kind of and stay where it
Right.
is more than if you have like even in your whole case, it's still like a water bath.
Yeah.
Well, it's still a water sort
Yeah.
of aqueous kind of situation and not
There's fluidics.
right. It's not hydrophobic sitting in front of it, where it's kind of like constantly just kind of sitting where it doesn't need to be. But yeah,
That's like Dr. Lema, we were just talking about like injecting methotrexate into oil. We were like just
well, that's an interesting reflex, by the way.
other day. He calls it his pepperoni bubbles because they're like you can see
Yeah.
the 2 methotrexate bubbles at the bottom of his oil, and we like looked back, they're like not, they're staying, they're hanging out.
Yeah, sometimes you see it at your next injection. The patient will come back in a week or two and they still have a yellow droplet that, floating in the oil from the last time.
That's
Injecting
it's
oil in general is just like kind of.
We need the Zypera.
Yeah,
do we have it yet? We don't have it yet.
No.
They said they were going to add in the Meditech.
I don't know. It was the same mess when I was down at Hopkins. They couldn't.
I'm a little
think
annoyed by that one.
I don't think it's on. Is it gone through P&T?
yeah.
It has gone through P&T. The only holdup is they can't get it in Meditech because can't strong arm IT to write the code. I don't know. And
They don't want to spend any money on Meditech anymore.
So
They're
make a paper
extending-
like I'm really getting annoyed that they're not just coming up with a solution to work around Meditech, because you can't deny patients something they need because you can't figure out how to write it into the EMR. That just doesn't seem right.
Yeah. Yeah, I mean, just for folks who don't know, Zypera is injected in the choroidal space, suprachoroidally. It doesn't go into the eye, so and it's a steroid, so it's a different way of delivering the med.
Yeah, the unique part about this is you waste a lot of it. And they can't figure out a way to document the wastage in Meditech. That's the problem.
I don't understand. You waste a lot of what? Zypera?
So, yeah, I mean, yeah, they give you like a whole ml. You inject like
Sell
20.
you the whole ml. Yeah.
Huh?
They sell you the whole.
Yeah, but the triamcinolone costs like $6 from the Kenalog. So I mean, it's
Yeah, but you've got to document. I don't know. I mean, I don't know what the issue is in terms of the reimbursement, but you have to document. It's infuriating to me because these are single-use vials. So the fact you got to document wastage out of a single-use vial drives me absolutely crazy. But you do.
It's not a narcotic. We waste a lot of stuff. That doesn't
Yeah,
make
I know.
sense. That's a very lame excuse. That sounds like an IT excuse.
No, CMS has a rule where you're supposed to, moving forward in future years, say you just use X amount of medication and either there was a negligible amount left, or you have to document how much you didn't use in the eye or in the body.
Really blame Zypera because they should have come out with a 0.2 ml bottle. You wouldn't have this problem.
It's true.
Yeah. All right. You guys have anything else?
No, good result for all that. Hopefully they don't get crazy PVR, but that's pretty good.
Yeah, no, that was excellent. Excellent.
Yeah, I was actually expecting PVR. Now I'm like,
I know. Well, I know it was like all leading up, and I was like, "Oh, we took oil out, just fine." But now I'm like, every time she comes in, I feel like
she looks great. So I'm like, okay. But
Post-op day 1, they all look good. So
yeah, exactly. I'm just they actually did the surgery like 5 months ago, and no, I'm just kidding. This is actually we actually did it last week.
Well, okay, cool. So next time, it's going to be one of the first years that's presenting, yeah?
Ah,
Yeah, I think Andrew's up next.
Andrew's doing it. Do we have a preview? Do we have a sneak peek?
Jim, there you go. Okay, we'll be waiting.
There's cases brewing.
Okay.
Okay. The witch's cauldron.
If they
There we go.
You won't see them actually.
All right. Awesome.
Okay.
Okay, I'll let you guys go early this time, okay? All right. Thanks,
Thank
guys.
you.
Great job. Great job.
Bye-bye.
Bye.
Have a good night, everyone.
good night.